to be with you again for another seminar. Before we start, I don't know whether any of us has any question arising from our previous topics that we discussed from last Thursday and last week Monday. The one on glaucoma and on cataracts. Is there any area that will need some clarification? All right, so I take the silence to mean that everything was clear. But feel free, anytime you have any in your reading, if you come across anything bordering on the eye or ophthalmology, I'm always available, even after this rotation. You can always contact me for any explanation on any of the areas that you will encounter from your past questions or whatever. You can always get in touch and we can have further discussion. All right, so today we are talking about diabetic eye disease. It's a very important lecture because as we all know, there are lots of diseases that affect the eye. We say the eye is the window to the body. And diabetes is just one of them. But why did I choose diabetes? I would have chosen to talk about hypertensive retinopathy or hypertensive diseases and the eye, or sickle cell disease and the eye. There are lots of autoimmune conditions that can also affect the eye. But this afternoon, we have chosen to talk about diabetic eye disease for a good number of reasons. Number one, this is a disease that is quite prevalent in our sub-region. Diabetes, the prevalence of diabetes globally is increasing because of changing lifestyle of people. People are living longer. So the longer people live, the more likely they are to live with most of the complications that come with it. And as primary, family physicians, we are often the first point of call. So it's very important that we are very knowledgeable when it comes to diabetes, which is very common, one of the commonest ailments you are going to encounter in your practice. At least we will have an idea the impact the disease can have on the eye and what we can do at our level as family physicians. If you have the knowledge, it will be very easy for us to make decisions and even advise our patients. So this afternoon, we are talking about diabetic eye disease. The eye is a very important sensory organ. In fact, most of what we do depends on good vision. Our daily lifestyle, our occupation, education depends on good vision. So anything that we can do to preserve this very important part of the body's function is something that we should take very seriously as we give our patients a comprehensive medical care. This is going to be the outline, some introduction, which I guess I've done already, epidemiology of diabetes and diabetic retinopathy. My talk will mainly center on diabetic retinopathy, but I'll let you be aware of some other complications diabetes can have on the eye. We'll not spend so much time on that, I'll just mention them. Then we go into diabetic retinopathy proper, which is a condition that does not develop overnight, okay? It's a disease that offers the opportunity for us to screen and institute preventive measures at the various levels, primary, secondary, and tertiary levels of prevention, so that people do not become blind. It's been estimated that most of the people who become blind from diabetes are people who are in the working class, and that is quite serious. So if you have people who are in the working class going irreversibly blind from diabetes, it has serious implications on our lives in general, on the socioeconomic lives, because these are people who can contribute effectively to the economy, and they have dependents as well. So it has a lot of repercussions if we lose opportunities for preventing blindness in such a large active population. So I'll take time to go through the pathophysiology of diabetic retinopathy. We'll look at the risk factors for the development of diabetic retinopathy. And then we'll look at the management of diabetic retinopathy. And most importantly, screening. Around that portion, I'll look at the situation with regards to screening in your environment, and what we shall discuss what we can do. All right. As usual, feel free to prompt me if there is any area you need clarification as I give the talk. All right. So this slide is something that you are more knowledgeable about more than me, because it's your field. It's mainly about diabetes and the types of diabetes. Okay. We know diabetes is a condition in which the blood sugar is unusually high, and there is abnormality with regards to metabolism of fats, carbohydrates, and protein. Mainly, we are aware of the two main types of diabetes, type 1 and type 2. We know that there are some other minor types like the gestational diabetes and other types, but these are what I want us to focus on for the benefit of our discussion on diabetic retinopathy. All right, so diabetes is quite common. It's been estimated that about 9.3% of the global population, that was from last year to 2019, representing about 463 million, have diabetes. And the number is expected to rise to about 10.9% of the global population, 10.2% of the global population by 2030, and 10.9%. So by 2030, which is just about 10 years from now, the number of people expected to be living with diabetes will be about 578 million. And in 15 years from 2030, the number is expected to rise to 700 million. This is quite significant. And the prevalence, for obvious reasons, is always high in the urban population and in high-income countries, okay, compared to low-income countries like this part of our world, sub-Saharan Africa. However, it will interest you to know that because of changing lifestyle, diet, and a lot of other factors, diabetes is really becoming a problem. Our main problem as healthcare in this part of the world used to be the infectious disease and all that, but now things are changing. At least for Ghana, I'm sure the situation is not different from what pertains in Liberia. The non-communicable diseases like hypertension and diabetes are really taking a toll on healthcare, and we have to be aware of this and institute measures we can be able to help our people in that regard. All right. So it's been estimated that about 50% of people who have diabetes don't know that they have diabetes. That's quite serious. And when it comes to diabetes and diabetic retinopathy, it is becoming increasingly common as diabetes is also increasing in this part of the world, in low and middle income countries. And like I've already enlisted, the rising prevalence of obesity, that increases the prevalence of or the risk of developing type 2 diabetes. Our diet is changing. People are living longer. Our lifestyle, people are more sedentary. Now, more people own cars. So from the house to the office, the person sits in the car, no time for walking at all, no time for exercise. So people are gaining weight, and the risk of type 2 diabetes is increasing by the day. Currently, of the about 285 million people who have diabetes globally, about 1/3 of them have some signs of diabetic retinopathy. And 1/3 of this number have diabetic retinopathy, which is vision threatening. I'll mention, or like as the lecture goes on, you get to know what are the vision threatening diabetic retinopathy. Okay, that also includes diabetic macular edema. All right, and as I said, is a leading cause of blindness among people of the working class. That's usually from 20 to 74 years. And with so much studies going on and research going on, it's been known that the identified modifiable risk factors, such as the sugar and the high sugar and associated hypertension, abnormal lipid profile, when they are controlled, they can help in preventing or in delaying the onset of diabetic retinopathy. Okay, and also prevent to a large extent in it leading to irreversible blindness. All right. So as I said, our talk is mainly going to be about diabetic retinopathy because it's a major cause of irreversible blindness in the working class. But diabetes can have complications on the refractive state of the eye. All right. We talked about refractive error, and in a previous lecture, the parts of the eye that are responsible for refraction of light, that's the ability of the eye's refractive apparatus to focus light on the retina so that images are formed clearly. We know the parts of the eye responsible for refraction are the cornea, which is most important, and then the lens, okay? The cornea does not change much in diabetes. What changes in the eye that leads to these refractive changes is mainly has to do with the lens. When the sugar goes up, you know, the lens or the crystalline lens is not vascularized. Okay, so it is nourished by the fluid that weaves it, the aqueous humor. When the blood sugar is high, the amount of glucose inside the lens also becomes high, more than what the metabolic capacity of the lens can meet. Okay, so instead of the glucose going through the normal pathway of being metabolized either through the anaerobic pathway, glycolysis, and then some of them through the sorbitol pathway. Because the metabolic process is overwhelmed, there will be accumulation of so much sorbitol. And sorbitol is very highly osmotically active. So this results in the lens. And it results in the lens eventually becoming more powerful, okay? The power of the lens becomes higher than usual. This can lead to the onset of myopia. The eye becomes myopic because as the lens becomes more round, it means that parallel rays that are coming from afar will be focused in front of the retina. So it can lead to the development of myopic changes. Okay, so that is one of them. Cataract is quite common. Like I said during the lecture on cataract, cataract is something that normally develops with age. And this usually occurs from the age of 60 years and above. But when you have cataract developing in someone who is younger, you have to rule out endocrine abnormalities like diabetes. Okay, everyone is going to develop cataract, but someone who has diabetes will develop cataract at a much earlier age. So if you have cataract in a patient who is 40 years, you have to evaluate and screen for diabetes. All right. It's also been shown that people who have diabetes have about 2 times risk of developing glaucoma. Here, with particular reference to primary open angle glaucoma. I think we talked about glaucoma in the previous lecture. So you know what primary open angle glaucoma is. There's a kind of glaucoma that is painless, and the patient gradually loses vision, peripheral vision, without being aware. So we call it the silent thief of sight. Okay, diabetes increases the risk of glaucoma to some extent. Another complication diabetes can have is, diabetes can result in microvascular complications. And as we are aware, peripheral neuropathy from the damage diabetes causes to the microvessels that are supposed to supply these nerves. The same thing can happen to the cranial nerves. In the introductory lecture, I talked about the fact that the eyeball has extraocular muscles which are responsible for moving the two eyes, in a very regulated fashion. Okay, so that we don't have perception of double vision and all that. These muscles are supplied by nerves, and the nerves have their own vessels that nourish them. So some of the microvascular complications of diabetes can affect the vessels that supply these nerves, just like we can have in peripheral neuropathy. So we can have palsy of the oculomotor nerve, which is the third cranial nerve, and palsy of the abducens nerve. Okay, this can happen in someone with diabetes who has these microvascular complications, and these complications that affect the cranial nerves is being shown that they usually resolve within a period of 6 months, and they don't usually involve the pupil. I want to explain this point. If you have someone with a third cranial nerve palsy, or especially the third cranial nerve palsy, because we know that the third cranial nerve has external fibers which are parasympathetic nerves, which are responsible for regulating the size of the pupil. Okay, because these microvascular complications occur from inside the oculomotor nerve to outside. When you have a palsy of the third nerve or of the oculomotor nerve from a complication of diabetes, they don't usually involve the pupil, i.e. the pupil does not become dilated. If you have a pupillary involving third nerve or oculomotor nerve palsy, it is likely to be due to a compression on the external surface of the nerve. So it could be from an aneurysm, okay, an aneurysm inside the brain, because the course of the oculomotor nerve, or where the oculomotor nerve passes, it passes along the posterior communicating artery. So if there is any aneurysm in that portion, it will press on the external surface of the eye, and that can result in dilatation of the pupil. Okay, that is what we call a surgical third nerve palsy. That's when you have a third nerve palsy with dilatation of the pupil, we call it a surgical third nerve palsy, and that is an emergency. You need to do imaging quickly to rule out an aneurysm and have that aneurysm treated before it bursts and leads to death. Okay, but third nerve palsy from diabetes, which is a microvascular complication, usually doesn't involve the pupils. unless it gets to the very, late stage. Okay, but in the early stage, the pupils are not involved. And what are the features of third nerve palsy? I said the third nerve or the oculomotor nerve supplies all the extraocular muscles except the lateral rectus and the superior oblique muscle. So it means that the inferior rectus, the superior rectus, the medial rectus, and the inferior oblique are all supplied by the third cranial nerve or the oculomotor nerve. Now, if there is a palsy of the third cranial nerve, what is going to happen is that because the C nerve is working and the superior, because the abducens nerve is working, and the fourth cranial nerve, which also supplies the superior oblique muscle, are working, the eye is going to turn out and down because the lateral rectus muscle moves the eye out. So if there is no counter effects from the medial rectus, the eye, which is being affected, will turn out. And the superior oblique muscle is responsible for moving the eye down. So if there is no counteracting force, it means that the eye is going to move down. And because of the pull of the lateral rectus, to move down and out. Again, the oculomotor nerve also supplies the levator palpebrae superioris. That is the muscle responsible for opening the eye. Okay, so if there is a palsy of the third nerve, there is going to be ptosis, okay, which is drooping of the upper lid. So when you have someone with ptosis, and then you open the upper lid and you see that the eyeball has turned down and out, then it means that there is a third cranial nerve palsy. All right, I hope that is clear. Now, after you have established that, go ahead and examine the pupil. Is the pupil involved or not? How do you tell if the pupil is involved? At an arm's length with your direct ophthalmoscope, look at the two pupils at the same time from an arm's length, okay? You will notice anisocoria. Anisocoria means difference in the size of the two pupils. So that if there is pupillary involvement, that eye's pupil will be bigger than the other eye. I hope this is clear. It's very important because when you have, we shouldn't miss a third cranial nerve palsy, which I've said there will be ptosis and the eyeball will turn out and down. And then if the pupil is not involved, like the size of pupils are equal, it is a medical third nerve palsy. But if that pupil is dilated, it's a surgical third nerve palsy. You need to rule out an intracranial space occupying lesion, like an aneurysm that can burst and the patient can die. I hope that point is clear. Are you with me? Hello?
Yes.
Hello.
All right, okay, thank you. Yeah, so another complication is, diabetes can lead to neuropathy. The cornea is innervated by the nasociliary nerves, which the branch of the ophthalmic branch of the fifth cranial nerve. Okay, so these nerves can be affected the same way diabetes can affect other nerves inside the body, and this can lead to reduced sensitivity of the cornea. All right, what this can lead to is that it can lead to recurrent erosions of the surface of the cornea. All right, so the patients may be having recurrent corneal erosions or corneal ulcerations. Okay, that may not initially be very painful, but it can be potentially blinding. And then another complication of in the anterior segment of the eye from diabetes is infection. Okay, blepharitis, which is infection or inflammation of the eyelid. We have stye and callusion. We talked about this in the second lecture. Yeah, and then what I want you to also take note of is that when someone has diabetes that is poorly controlled and has resulted in what we are going to talk about in the next few minutes, an advanced diabetic eye disease, okay, or like diabetic retinopathy, and most of the retina cells are not getting enough blood supply, there is going to be elaboration of what we call vascular endothelial growth factors, which will result in the formation of new vessels. And some of these new vessels can develop in the posterior part of the eye as well as in the anterior part of the eye, on the anterior part of the eye, specifically on the iris. Now, this development of new vessels or abnormal vessels on the iris is what we call rubeosis iridis. All right, I'll show a picture. Now, these development of new vessels can lead to the closure of the angle. I think from last week's lecture on glaucoma, I talked about the angle. The angle is the space between the cornea, the peripheral cornea, and the iris, where there is a sieve-like meshwork structure that allows drainage of the aqueous from the anterior chamber into the episcleral venous system and then into systemic circulation. So these new vessels that develop in the angle can result in closure of the angle and result in angle closure glaucoma. That can result in a very high pressure inside the eye, very, very painful, and it's also potentially blinding. Okay, so this is an eye which is very angry. You can see the vessels on the iris. I'm not sure whether the picture is clear to you, but these vessels on the iris are not normal. This eye has cataract as well, okay? The eye looks red and the pressure inside this eye will be very, very high. So this is what we call rubeosis iridis. It's something that will develop from diabetes that has been, diabetic retinopathy that has been neglected. So that's why this lecture is very, very important. We wouldn't want to see this because it's quite difficult dealing with it. Okay, the kind of glaucoma, the particular type of angle closure glaucoma that we have when this develops is called neovascular glaucoma, because the glaucoma developed because of the formation of new vessels. The pressure of the eye can be very high and it's very difficult to control. No ophthalmologists want to experience this. But as we have diabetes very common, if we don't manage the diabetes well at various levels, these things are inevitable. All right. So now let's, for the next few minutes, talk about diabetic. Please, when it's about 10 minutes to time, Patrick, Cynthia, any of you alert me. All right. So I've talked about the fact that the eye is the window to the body, and by examining the eye, we can see cells without having to take a biopsy. You can see the blood vessels, okay, and the blood cells actually circulating when we examine the eye. And that instrument we call the direct ophthalmoscope gives us that opportunity because it gives a magnified image of the retina and its blood vessels, about 5 times larger than their normal size. Okay, so those of you who are currently doing the ophthalmology rotation, please take time to read about the ophthalmoscope and the various uses it can be put to. There are lots of videos on YouTube, okay? How to do fundoscopy. It's an art. As you watch the videos, you try to practice, okay? It's a skill that when you find it very, very invaluable. It will be very, very important for you. And those who are here to do the ophthalmology rotation, please make sure that by the time you finish, you are very good with fundoscopy because you can see the eye is a window of the body. You can see a lot of what is going on inside the body by just examining the fundus, okay? Now, most ophthalmoscopes available now have certain filters. They have the blue filter, some of them have a green filter. The blue filter gives a blue light that you can use to examine the anterior surface of the eye, like the cornea. in the initial lectures, I talked about the fact that if there is any ulceration or any abrasion on the cornea, and you stain with fluorescent, and you shine the blue light on it, the blue light will absorb, the fluorescent will absorb the shorter wavelength of the blue, and then fluoresce means it's going to give back to you light of a longer wavelength, which is more like the green the yellowish green that you see. Then we have a green filter. The green filter is very, very useful because if you are examining the fundus, the green filter actually help you to outline the blood vessels, the retinal blood vessels very well. And if there is any abnormality, it becomes very, very obvious, like leakage of a blood vessel, which does happen in diabetic retinopathy. So take notes. The next time you see an ophthalmoscope, it's not just a white light, but especially if you want to examine for abnormalities of the blood vessels, which is a feature of diabetic retinopathy, make use of the green filter. So the normal fundus doesn't have any exudates or hemorrhages, okay? So if you find any of these, it means that there is a problem, all right? Yeah. When you are doing fundoscopy through an undilated pupil, you can only see just a very small portion of the retina, just the posterior pole. You can see the disc, and perhaps, yeah, you can see the disc and some area around the fundus, okay? But when you have a dilated pupil, it affords you the opportunity of seeing a wider area. It's not as clear as I saw it, sorry for that. But I just want to depict, okay, this is to depict to you how a normal fundus looks like, okay? So that's the disc, and then from the disc we have vessels emanating from the disc, okay? So we have the superotemporal arcade, okay? Then we have the supernasal. This is the temporal part of the fundus. This is the nasal part, okay? Then you have the inferonasal. Now, between the two temporal arcades is what we call the macula. And at the center of the macula is the fovea. All right, take note of this. So the normal fundus doesn't have any hemorrhages or any exudates or anything. It looks very nice like this. All right, I want us to now briefly look at the pathophysiology of diabetic retinopathy. Please, is there any question at this point? Is there any question at this point?
No questions.
All right, thank you very much.
But we're having challenge with our internet.
Oh my goodness, that's very unfortunate. So if there is any network problem, and kindly alert me so that I can go over the area I got to where you were not getting it very well. All right, so the retina, as I said, has its own vessels. It has arteries, it has arterioles, it has capillaries, it has venules, and it has veins. The larger vessels are located in the nerve fiber layer, as well as in the ganglion cell layer. And then the smaller vessels, those are the capillaries. They are located much deeper. Okay, so closer to the RP. Okay, the retinal pigment epithelial layer. Okay, and the last time, I think in the introductory lecture, I said that the eye is one of the immune privileged sites inside the body, like the testis, the brain. Okay, so we have what we call blood-brain barrier. We have blood-testis barrier. We also have blood-retinal barrier. Okay, and these are controlled by tight junction. They have no fenestration because the eyeball is so delicate that everything coming inside the eyeball should be tightly screened or regulated. If there is any problem with these tight junctions and some of the contents of the blood gets inside the eye, they cause severe damage. That's why when there is uveitis, when there is inflammation of the uvea, these tight junctions are disrupted and it results in the passage of proteins inside the blood, okay, getting into the eye itself, and that leads to damages inside the eye that can lead to blindness. All right. Now, there are some cells that surround these capillaries. We call them pericytes. They provide support and they also control the growth of these capillaries. Okay. And then these pericytes have basement membranes. So diabetic retinopathy actually is a microvascular complication of diabetes, just like we have in diabetic nephropathy. Okay, and maybe I may forget to say it, but let me say this now. People who have diabetic nephropathy have a very high risk of developing diabetic retinopathy, and vice versa. All right, because the pathophysiology is almost the same. Okay, so when these microvascular complications of diabetes is occurring, the pericytes that are responsible for the growth and support of these capillaries are destroyed. Changes occur in the epithelial cells of the capillaries. Okay. When we have about 75% of these pericytes lost, the tight junctions are no longer able to perform their functions very well. The structural support of the capillaries are lost. That's when you see bulging of these microvessels, what we call microaneurysms, okay, or circular microaneurysms. That's a term you hear when we talk about diabetic retinopathy. Okay, and there is more growth because of the changes inside the epithelial cells. There is ischemia. The ischemia can result in more growth of some of the endothelial cells and result in tight loop microaneurysms. All right. Yeah. So these loss of pericytes is very, very important. Will result in breakdown of the blood retinal barrier. All right. And what does this lead to? It will lead to the formation of exudates, intraretinal lipid exudates, because of leakage of proteins and lipoproteins from the blood, from the plasma. These exudates will be located in the outer plexiform layer of the retina. There are many layers of the retina, okay? So this one is a bit deeper inside the retina, all right? And you will see it as a yellowish or golden discoloration when you do fundoscopy. Okay, the loss of these pericytes and hence the breach of the tight junctions can result in leakage of fluid at the macula. All right. So I said the other time, the macula that has the fovea is the most sensitive part of the eye. All right. And if there is fluid or there is edema at the macula, it affects vision significantly. All right. As the leakages continue, there is more damage to the vessels and there is hemorrhage. Okay, hemorrhage like inside the retinal nerve fiber layer. Okay, if it's a superficial hemorrhage, we call them flame-shaped hemorrhage. Okay, and if the hemorrhage occurs deeper within the retina, we call that dot blot hemorrhages. All right, so this change will continue going on. There will eventually be ischemia to certain parts of the retina. The ischemia that occurs in the superficial part of the retina due to damage to the retinal nerve fiber layer will result in those whitish, fluffy appearance at the fundus we call the cotton wool spots. All right, cotton wool spots. So there is damage to the capillaries. Unfortunately, there is not so much collateral vasculature inside the retina. So if you have a particular capillary being destroyed or being blocked, then it means the part that is supposed to supply is going to be hypoxic and eventually lead to death of the retinal nerve cells in that particular region. All right. Good. Now, in response to this hypoxia or reduced amount of oxygen to those cells, the normal cells around are going to produce this particular factor we call the vascular endothelial growth factor. This is very, very important. Now, this one is produced in an attempt for to help the retina to produce new vessels, all in a to reperfuse the area that is not getting enough blood supply. And the vascular and endothelial growth factors will result in the formation of new blood vessels that are not as strong. I'm getting some feedback. That are not as strong as the original blood vessels. All right. Yeah. So later, with the formation of all these factors, the vascular endothelial factors, is going to result in abnormalities of the capillaries, development of new capillaries, okay, and vessels that can lead to some of the late developments we have in diabetic retinopathy. Okay, so new vessels are formed. They are immature. These don't have the normal pericyte. So it means that they don't have very strong tight junctions, and they have fenestrations. The new vessels that are formed, they have fenestration. That means they can bleed and they can leak. Okay, so leakage of the content of blood into the retinal tissue from these new vessels or abnormal vessels is the main underlying factor for what we see in diabetic retinopathy. Okay, and later, as there is leakage and bleeding, fibroblasts are released into the retina and then into the vitreous. Okay, and fibroblasts, as you know, will eventually lead to the formation of contraction bands. It can cause some fibrous. They can cause the formation of some fibrous tissue that can in turn stretch on the retina and cause more bleeding and cause tears in the retina, okay, or breaks in the retina. The retina is a very, very delicate tissue, and those breaks in the retina can result in the detachment of the retina, okay, in what we call rhegmatogenous retinal detachment. So there is a break in the retina, and as you have fluid inside the retina, that fluid is going to now cause more detachment of the retina. Like I said initially, these vascular endothelial growth factors that are produced can also result in the formation of new vessels on the iris, what we call rubeosus iridis. So how common is diabetic retinopathy? In fact, for most people, the first point has to do with people who have diabetes at the time diabetic retinopathy already at the time they are diagnosed. If you can remember very well, I said about 50% of people are talking about not knowing that they have diabetes at all. And diabetes retinopathy develops over a long period, okay? So about 20% already have diabetic retinopathy at the time they are diagnosed. That's why it's important that when you diagnose someone newly to have diabetes, you should have the person have the fundus examined, or the person should have a fundoscopy done to rule out a pre-existing diabetic retinopathy. And for people who have normal fundus or no feature of diabetic retinopathy, most of them are going to develop diabetic retinopathy after 10 years. About 40 to 50% of them will develop diabetic retinopathy after 10 years. And after 20 years of diagnosis, this point is very, very important, and I want you to pay attention. After 20 years of diagnosis of diabetes, people who have type 1 diabetes, almost all of them are going to have features of diabetic retinopathy. And 60% of those who are type 2 will have diabetic retinopathy after 20 years. What does this tell us? It tells us that the longer you live with diabetes, the more your risk of developing diabetic retinopathy. All right. So these are the risk factors for development of diabetic retinopathy. So poor blood sugar. Okay. This particular slide that I talked about, the after 20 years, it can even happen even when the sugar is well controlled. Okay. However, if the blood sugar is poorly controlled, then the retinopathy develops much earlier and it progresses much faster. So a very important risk factor is poor control of the hyperglycemia. The next important risk factor for the development of diabetic retinopathy is blood pressure. When the person has a hypertension that's also not well controlled, it accelerates the development of diabetic retinopathy, as well as the progress of the diabetic retinopathy from non-proliferative diabetic retinopathy to proliferative diabetic retinopathy, all right? And then eventually to blindness, all right? The more you have microaneurysms, I've said that when you have loss of these parasites, okay, it can result, they result in the formation of circular microaneurysms. So the more you have the microaneurysms, the more your risk of developing diabetic retinopathy. The next very important factor I've mentioned already is the duration of the diabetes. Okay, so it means that no matter how well the BP, the blood cholesterol, no matter how long the sugar is controlled, as long as the person lives, the longer the person lives, the higher the risk of developing diabetic retinopathy. That point should be made very clear. All right. And then people who have proteins and albumin in their urine, this could be a sign of diabetic retinopathy. As I said, diabetic nephropathy. Diabetic retinopathy and diabetic nephropathy go hand in hand. Okay. So usually when I diagnose someone to have diabetic retinopathy, I have to screen the person for diabetic nephropathy and then refer appropriately to the physician. All right. So when you have someone with proteinuria, you have to know that the person's risk of becoming blind from diabetic retinopathy is very high. I've talked about abnormal cholesterol or dyslipidemia. Okay. The higher or the poorer the cholesterol is controlled, the higher the risk of developing diabetic retinopathy. And then last but not the least, pregnancy. People who have diabetes and become pregnant have a higher risk of developing diabetic retinopathy. This means that while someone is pregnant, this is different from gestational diabetes. This is someone who has diabetes and has become pregnant. Okay, the pregnancy hormones and all the things that are associated with it increase the risk of developing diabetic retinopathy and progression of the diabetic retinopathy. So ideally, every pregnant woman who was diabetic before becoming pregnant should have the fundus or the eye examined at least 3 times, one in every semester. Sorry, one in every trimester of the pregnancy. Okay, and more frequently if any abnormality is detected at any session of the pregnancy. Sorry, I forgot the last risk factor, smoking. Someone who is diabetic and smokes has a higher risk of developing diabetic retinopathy. I want us to look at briefly look at the classification of diabetic retinopathy. Okay, so they can be classified as background diabetic retinopathy, which is also known as non-proliferative diabetic retinopathy. Okay, so when you examine someone who has diabetes, the fundus may be normal. Normal means that there are no microaneurysms. Okay. However, if the person has the development of these microvascular complications and there is loss of pericytes, then they will begin to form microaneurysms. All right. And if there are no associated ischemic changes like these cotton wool spores or hemorrhages, then we can say the person has background diabetic retinopathy or non-proliferative diabetic retinopathy. Now, this person will have to make serious, you have to control the sugar very well. So with lifestyle changes, control the diet, control the blood pressure very well. And this person doesn't need treatment of the retina. They need observation. Okay, so you can decide to let the person have a review of the retina after about 9 months to about a year. Okay, if the fundus is normal, they should just have an annual fundal examination or an annual dilated fundal examination. Okay, then there is another stage we call the pre-proliferative retinopathy. So here there's so much damage to the capillaries that there is ischemic changes. Okay, so lots of dust blood hemorrhages, cotton wool spots. Okay, and abnormalities with the vessels. Okay, so you have but here, as of this point, the level of ischemia hasn't gotten to the point where the retina is producing the vascular endothelial growth factors. That will result in the formation of new vessels. Okay, so in someone who is pre-proliferative, that's they have all these severe features. I'll talk about the particular features that will let someone qualify as being pre-proliferative or as having pre-proliferative diabetic retinopathy. This person may need laser treatment. So it means you have to refer this patient to an ophthalmologist, okay, who can do what you call pan-retinal photocoagulation, all right? Especially if this patient is someone who may be lost to follow-up. If the patient is very responsible, whilst you have involved the ophthalmologist, they can decide to keep a very close eye on the patient before even considering doing the laser photocoagulation. All right. The next stage is where new vessels have already started to develop on the disc or any other part of the retina. Now, at this stage, the patient needs urgent referral and for what we call a pan-retinal laser photocoagulation. Okay, I'll show a picture of what happens when you do the laser. Now, what the laser actually does is that we use the laser to destroy most of these new vessels, as well as to reduce the oxygen requirement by the whole retina. Okay, because if there is so much hypoxia, that is when there is formation of new a lot of these vascular endothelial factors and will lead to the formation of a lot of these new abnormal vessels. So when you do the laser photocoagulation, we destroy these new vessels and also try to limit the amount of normal retina to maybe like just those left at the posterior pole. So we try to destroy most of the retina at the periphery, okay, so that the oxygen tension required will be less, and there will not be a lot of secretion of these vascular endothelial growth factors. I hope that point is clear. It will become clearer as it goes on. Another classification or another class of diabetic retinopathy is maculopathy. This one has to do with formation of or like the accumulation of fluid inside the macula. All right, when fluid accumulates inside the macula, I showed you where the macula is, the area between the two temporal arcades. Okay, so when fluid accumulates there, the vision is impaired. Okay, and this fluid may contain proteins and lipoproteins. Okay, so when they dry up, you see them as exudates. They also require laser, okay, to the macula to destroy the new vessels or the abnormal vessels that are leaking these contents of the plasma into the macula. Now, we don't only use laser in treating macular edema. We have intravitreal injection, okay, of certain drugs we call anti-VEGFs. And then we also have some steroids called triamcinolone that can also be used in suitable patients, all right? These points are very important. So these are the abnormalities. So when there is microvascular complication of diabetes in the eye, it can result in either ischemic areas or leakage, all right? Leakage of blood into the retinal tissues, all right? So as I've mentioned already, you can have the formation of microaneurysms, you can have leakage in the macula as exudates or edema, you can have hemorrhage. And the hemorrhage, we have dot blood hemorrhages, which are deeper in the retinal nerve fiber tissue. Then we have flame-shaped hemorrhages, which are more superficial, all right? And then abnormalities of the blood vessels. The ischemic changes, you can have formation of cotton wool spores, as well as new blood vessels, all right? Now, these are the sight-threatening complications that can develop from the pathological processes occurring here. So when someone has a macular edema or diabetic maculopathy, it is sight-threatening. It's an emergency. It needs to be treated. Then the diabetic macular edema needs to be treated. Someone with formation of new vessels, that's proliferative of diabetic retinopathy, needs to be treated. What's the problem? Please excuse me just a second. Is it an emergency? If it's not, evaluate, Irene, evaluate and let me know. Sorry, let's continue. So someone who has proliferative diabetic retinopathy, it can be potentially sight-threatening, okay? Someone who has developed new vessels can bleed inside the vitreous and have what you call vitreous hemorrhage. It's also potentially sight-threatening. It needs to be managed. It needs to be treated by an ophthalmologist, all right? And then all these will eventually lead to tractional retinal detachment that can lead to irreversible blindness, all right? So sorry for the long talk, all theory. I'll show some pictures from now. There may be difficulty in appreciating this if you are not very used to examining the fundus, and that's why I encourage that when you have the opportunity of going through the ophthalmology block, please let patients be dilated and use your ophthalmoscope to look at the fundus as much as you can, so that when you see any of these, you don't have to know exactly how, what is a dot blood hemorrhage, what is a flame-shaped hemorrhage, what I will expect from you is that you know what a normal fundus is, so that when you have someone with diabetes and then you see any change, any abnormality, you can refer for an ophthalmologist to have a review and then now continue with the management of the eye. I hope that point is clear. So this is an eye, this is a fundus. You can see these yellowish lesions here. Those are exudates, okay? And you can see blots or dot blot hemorrhages here. These are quite difficult to appreciate, whether what you are seeing here is a microaneurysm or is a dot hemorrhage. Clinically, it's quite difficult to tell. Okay, we can see that after an investigation we call fluorescent fundus angiography, where we put a fluorescent dye into the blood vessel of the patient, and then we take serial fundus photographs, all right? If that is a microaneurysm, okay, there's going to be continual leakage. If it's just a hemorrhage, the leakage is not going to be continual. So that is quite difficult to differentiate clinically. These are pictures of fundus that have exudates. So just seeing exudates in someone who has diabetes should tell you that they are on the verge of developing diabetic retinopathy. Very common cotton wool spots, okay? Cotton wool spots, when you see that, and then you see these exudates, and you see these hemorrhages that appear to be all around, almost in every quadrant of the eye, it's a sign of severe non-proliferative diabetic retinopathy, okay? All right. Sorry, I included this. It may be difficult for you to appreciate, but by and large, when there is edema at the macula, it results in decrease or loss of vision. All right, and with a direct ophthalmoscope, it may be difficult to appreciate thickening of the retina. You require to use a slit lamp with a fundus lens to be able to appreciate that, all right, or with a fundus camera to be able to appreciate that. Now, what I want you to take from macular edema is when someone has a reduced vision, maybe instead of vision being 6/6, and the vision is about 6/60, and you examine the eye, there is no cataract, and the vitreous is clear. That means you can see a very good red reflex. You have to do the pinhole, okay? If the loss of vision is due to a refractive change occurring inside the lens, the visual acuity will improve. If it's due to a macular edema, the visual acuity is not going to improve. It's rather going to worsen, all right? So having done that, if you see any exudates are quite easy to pick. At the macula, you should suspect macular edema and refer appropriately. Okay, so that's the fovea. The whole of this is the macula. At the center is the fovea. Then we have exudates. Okay, we have a criteria. It's not every macular edema that is considered significant, but for your level, I don't think it's very important to be able to identify what a clinically significant macular edema is, because there are some parameters that we use that may be difficult for you to detect. So yours is pick a patient who has a reduction in vision, who has diabetes, and then if you see any exudates or any other abnormalities, you have to refer to an ophthalmologist. Okay, so all these are pictures. The slides will be available so you can have a look. All right. So here there are exudates. The macula appears thickened. It's quite difficult to appreciate it by just looking at it. Okay. This one, unfortunately, is remnant of a previous macular edema that should have been well managed. When it gets to a point like this part of the retina becomes ischemic, and the eye becomes irreversibly blind. You cannot reverse it when it gets to a stage like this. This is an eye that had proliferative retinopathy. New vessels develop, and the new vessels, because they are so fragile, they bleed. So here, the bleeding is between the membrane that surrounds the vitreous and the retina. So it looks more like a pre-retinal hemorrhage. With time, this hemorrhage will extend anteriorly into the vitreous. So this one, if you do fundoscopy and you can see this, it tells you that the vitreous is clear, and the hemorrhage or wherever the bleeding is has not gotten into the vitreous yet. All right. How do we treat macular edema? This one is just for your information, because you are not going to manage or treat macular edema. So we use laser. We can give injections, what we call the anti-VEGFs. Okay. As I said, the main pathophysiology in diabetic retinopathy, a very key component is what we call the VEGFs, the vascular endothelial growth factors. Because of the ischemia, the retinal cells produce the vascular endothelial growth factors in an attempt to revascularize the retina. The new vessels that are formed are abnormal. They don't have the tight junctions. They leak, they bleed. All right. So when you give this intravitreal or injection into the vitreous, they are able to mop up these vascular endothelial growth factors and prevent the formation of new vessels, or use laser to destroy the leaking vessels, all right, so that there's not going to be any further accumulation of fluid inside the macula. So that's a picture of an eye that is receiving an injection, okay, into the vitreous. So it could be either the anti-VEGFs, if you have heard of Avastin, a brand name, okay, Avastin is one popular anti-VEGF, okay. The actual active ingredient is bevacizumab, all right. Then we have Lucentis. Then some people, especially if the person has had a cataract surgery, or the person doesn't have a high eye pressure, a very cheap alternative we give is steroids, triamcinolone, that we can give to help to dry up the macula. All right. Okay, I'll be finishing soon. In order to ensure that you have been paying attention, when I'm done with the lecture, we are going to do some small quiz. So please pay rapt attention. All right. We shall answer some 10 simple true or false questions to help me know whether you were sleeping all along or you were actually paying attention. Adult learning is not easy. So these are signs that shows that the person has severe non-proliferative diabetic retinopathy that can easily progress to proliferative diabetic retinopathy. So when you have microaneurysms in all the quadrants, abnormal veins in at least 2 quadrants, and then there's something we call intraretinal microaneurysms. Sorry, this one will be difficult for you to know, but as I said, the take-home point is know that someone with diabetes is at risk of developing diabetic retinopathy that can result in irreversible blindness. So regular screening, all right? Get used to knowing how the normal fundus looks like. If you pick any abnormality, any hemorrhage, any exudates, any new vessel formation, refer promptly, all right? Okay, let me skip this. Okay, so this is an eye with pre-proliferative, almost proliferative. So there are some features. So here you find the hemorrhages occurring in all the quadrants. This one is just a section of the retina that the fundus picture has been taken. But you have things like this occurring in all the 4 quadrants of the fundus. Okay. One investigation that we do when it comes to diabetic retinopathy, just for your information, is what we call fluorescein angiography. All right. I think I've described it already. The last stage, the most feared, is the proliferative diabetic retinopathy. So you have new vessels forming in the retina. These new vessels, like I've said, and I'm repeating it, they are not normal. They are very fragile. They leak and they bleed easily. And that is what results in all the problems with blindness resulting from diabetes. Okay. They have very little fibrous tissue, they is inside and all that. So this is an eye with proliferative diabetic retinopathy. If you look closely, you may find some abnormal blood vessels, and then you have this fibrous tissue, okay, from previous leakage of the proteins and the fibroblasts, okay, into the vitreous. So there is fibrosis, and these fibrous bands can pull on the retina and cause retinal detachment, okay. So when you have PDR or proliferative diabetic retinopathy, there can be pre-retinal hemorrhage. There can be hemorrhage into the vitreous itself that can present as a sudden loss of vision or retinal detachment. And again, like I said, with ischemia occurring at the posterior part of the eye, there can be formation of new vessels in the anterior part of the eye, on the iris, what we call rubeotic iridis, or yes, rubeosus iridis, all right? This can lead to a secondary type of glaucoma called neovascular glaucoma. The eye pressure is going to be very high. The patient, by the time he presents with this, is already blind, no perception of light. But it doesn't end there. Not only is the patient going to be blind, but the patient is going to be in perpetual pain. So we have to treat aggressively to try to regress, to cause all these new vessels to regress. Sometimes the eye has to be even taken out when it gets to this point. And this is where we don't want it to get to. So the crust, of all my talk is that let's be aware that diabetes can become very blind. We know the risk factors. Regular screening is key, okay? And if we can have a look at the fundus and see any of these abnormalities, we can refer appropriately. So all these are pictures of people with fundus showing proliferative diabetic retinopathy. Okay, so how do we treat? We use laser to destroy all these abnormal vessels. Okay, and sometimes we do surgery, vitrectomy, remove, especially when someone has had vitreous hemorrhage that is not clearing after a period. Okay, or behind the vitreous hemorrhage, if there are signs that more new vessels are developing, we have to remove the vitreous surgically, and then now treat the areas where the new vessels are developing with laser. Okay, so this is an eye that has had a laser treatment. So this is fresh, recently applied. Okay, all these spots are laser spots. So these are done at the periphery because where the part of the retina that is lasered can no longer see. So we don't laser the posterior pole. We don't laser where the optic disc is and the macula is, unless there is a macular edema. There is a special laser we do. But we laser the peripheral part of the retina so that it will reduce the proportion of the retina that doesn't get enough oxygen and hence will result in the production of the vascular endothelial growth factor that is responsible for formation of new vessels. Okay, so typically you can see this picture. It has been lasered at the periphery. The central pole has been spared. If this one is done early enough, at least the person can have some vision, but these patients will have eternal vision because all these parts that have been lasered cannot see. All right, they cannot see, but at least they can preserve their central vision for the rest of their life with better control of their sugar, their cholesterol, their hypertension, change in lifestyle, and all that. I'm just about to end, okay? And if you have been following closely, I've been talking about screening, all right? When you have somebody who has diabetes and the person is less than 30 years, most likely the type 1, okay? The retina has to be examined within 5 years of diagnosis. And when everything is normal, you have to see the person. The patient should have an annual check of the fundus every year, all right? If the patient is older than 30 years, as we find in most cases of the type 2, the patient has to have the fundus or the retina examined at the time of diagnosis or soon after diagnosis, and then when it's normal, once every year, all right? I've already said that when someone is pregnant, their risk of developing diabetic retinopathy is very high, and they can progress and lose their vision, especially when it's someone who was diabetic and became pregnant. So they should have eye examination once every trimester. So this is a summary. So when you screen and the patient has normal fundus or maybe just some few microaneurysms, okay, continue the routine care and review annually or like every year or like 9 months to 1 year. That's if you see signs of background retinopathy. All right. If there are more severe features, okay, like lots of exudates, lots of hemorrhages, or there are other associated factors like poor control of the sugar, okay, sometimes it improves suddenly, there is a fluctuation of the sugar, or there is associated hypertension and renal disease. You have to review the person, and then like the person has not developed new vessels yet, you have to review the person earlier So between 3 to 6 months, the person should have the eye examined. Okay. And then when there is an urgent drop in vision, or you notice exudates in the macula close to the fovea or close to the center, or macular edema, or if there are any unusual findings in the retina, this is a patient you have to refer urgently to an ophthalmologist within a month. Okay. If there are blood vessels in the iris, that's rubeosus iridis, or blood vessels in the retina, or there is any hemorrhage in the vitreous or preretinal hemorrhage, refer urgently to an ophthalmologist within a week. All right. This is the last slide. So it's just a summary. So as a family physician, you have to let your patients who have diabetes understand that it's very important for them to take good care of their body and manage with you very well their blood sugar. All right. And the sugar should be well controlled. Their glycated hemoglobin should always be kept ideally less than 7%. All right. Their blood pressure, when someone has diabetes, you should aim at controlling their blood pressure very well, at least around 140/80 or below. Their diets, having time for regular exercise, avoiding smoking, okay, and then the screening that I told about. All right. So that's the end of the talk. These are the references. All right. I'll make the slides available to you. Yeah. So any question before I start asking you my few questions? Sorry, it's been more theory. But there are some few take-home messages I don't want you to miss. Being aware that they can be potentially, diabetic retinopathy is a very important cause of blindness in the working population. Diabetes prevalence is increasing, so does diabetic retinopathy. 1/3 of people who have diabetes have diabetic retinopathy, and 1/3 of those who have diabetic retinopathy have vision-threatening diabetic retinopathy. That's those who have the proliferative diabetic retinopathy, macular edema, and what do you call it? Rubeosus iridis. Okay, there are people like that there. We have to regularly screen. If we cannot screen ourselves, we have to refer them to a place where they can be screened. All right, so that we can prevent them from becoming blind at an earlier age. All right, thank you very much. Any question?
I said there was a lot of interruption.
Yeah. Sorry for that. I wanted to be notified at any point where there was interruption so that I could go over.
I think we'll follow the recording.
All right.
Because we have a lot of breakup in between because of the network.
All right, that'll be fine. So later, when you follow the recording and you have any question, like I've been saying, prompt me. Okay. How is screening of the eyes of people in diabetes like in Liberia at your center? Is there a program like that? In Ghana here, most centers don't do it because of logistical challenges and a lot of other issues. Yeah. So how is the situation in Liberia? Screening for diabetic retinopathy?
No, presently there's no kind of robust screening site. No. Basically, just
Liberia, ELWA.
Now here in ELWA, basically patients possibly complain.
Yeah.
Maybe the diabetic clinic may decide to refer the patient for eye checks.
All right.
We have not had the occasion to do that.
All right. So
been improved.
Yeah. as we are getting more eye care professionals, as we are training more with time, and then as we are having more people having diabetes, we have to institute programs for screening for diabetes. Okay. Yeah, but at least, like I said, let us make an effort to learn fundoscopy. Most of these pictures and all that, you can follow some of the videos on YouTube and you can easily learn the art. And whilst you are in the ophthalmic block, sometimes the ophthalmic nurses can be very useful because they've been seeing this over and over and over, so that you can easily tell a normal fundus from an abnormal one and then refer appropriately. All right. Okay. Is there any other comments, question before we round up with my questions?
Okay. Thank you very much, Doc. This topic is very helpful. And like in our practice, we always see diabetic patients. So we'll try to put that in our practice to advise the diabetic patient to have an eye screen. Yes.
Yeah. Thank you very much. Thank you very much. So that voice sounds like Cynthia.
No, that's not Cynthia. That's Dr. Koha.
All right. Nice to meet you, Dr. Koha. So Cynthia couldn't join us today. Yeah, I think I had a notification. All right. I had a notification that Cynthia may not be able to join us for today because he has to go to the college for some official duty. Yeah. Fortunately, because Cynthia is in the ophthalmic block, I think during one of the tutorials, I can summarize this for her as she goes through the slides. All right. So, yeah. Pop-up quiz. Are you ready? It's just true or false. So first question. People with diabetes are more likely than people without diabetes to develop certain eye diseases. True or false?
True.
Very easy. Yeah, so it's true. Diabetic eye disease includes diabetic retinopathy, a leading cause of blindness in adults. And people with diabetes, like I said, have a higher risk of developing cataracts at a much earlier age. And then also their risk of developing glaucoma is about 2 times the normal population. And the longer someone has diabetes, the more likely they are to develop these eye diseases. I hope that point is clear. The longer someone, yes, I want you to really take note of that. Question 2. Diabetic eye disease usually has early warning signs. Let me modify the question a bit. So let's say diabetic retinopathy usually has early warning signs. True or false?
False.
Any volunteer?
I think it's true because most of the time,
by the time they are diagnosed, about 20% already had the disease.
No, the problem is that the patient, that is one.
You have divided opinions, I can see. So one person at a time, and then give reasons.
Yeah, what I'm saying is that the early warning signs are there.
Yeah.
But possibly they don't take it serious. You know, they don't consider it as something that is very necessary to seek for care.
All right.
Because when it comes to, especially when it comes to maybe some vascular diseases, some of them will complain to you if you continue to interrogate them. They will tell you, oh, some time ago, sometimes I can just maybe see double, I can just see this, but they don't consider it to be something maybe connected to their diabetes. So if you take a detailed history, you see that actually there have been signs that started earlier, which possibly they ignored.
Yeah, very good contribution, Patrick. Yeah, very good. Yeah, so as I said, modifying this to specifically with diabetic retinopathy. I think, Patrick, your point is quite accurate. But you are rather looking at like eye disease in general, like things like refractive error, cataracts that are associated with diabetes. But when it comes to diabetic retinopathy in particular, you know, the retinal nerve, the retina doesn't have a lot of sensory nerves. So the main reason why diabetic retinopathy screening is very important is that, especially with diabetic retinopathy, they may not have a lot of early warning signs, okay? So by the time they become symptomatic, things may be almost getting to the end stage. That's why it's important we screen them, okay? So diabetic retinopathy develops over a long period, and it gives us a very good window of opportunity to screen them even before they become symptomatic for diabetic retinopathy, all right? So I'll go for false, okay? And that's the reason that I've given. Good attempt, Patrick, well done. So often there are none in the early stages of the disease. Vision may not change until the disease becomes severe. So this is in particular reference to diabetic retinopathy. Patrick, your point may hold.
Let me see. Oh, the net.
Any help? Or you answer together unanimously? For internet connection. That is, yeah, that's true. Yeah, that's true. So everyone with diabetes should go for,
yes, that's true.
Yeah, should get an eye examination through dilated pupils at least once a year, okay? Because diabetic eye disease usually has no symptoms. Regular eye exams are important for early detection and timely treatment. Good. Question 4. Diabetic retinopathy is caused by changes in blood vessels in the eye. True or false? Let me see those who were paying attention. Diabetic retinopathy is caused by changing. Very good, very good. So that's true. Yeah. So in some people, blood vessels in the retina may swell and leak fluid. In other people, abnormal new blood vessels grow on the surface of the retina. I think that is what I took time to explain. Next question. People with diabetes are at low risk for developing glaucoma. This must be easy. I just said it. True or false?
False.
Good. It's false. So glaucoma is twice as likely to occur in people with diabetes than those without the disease. Okay. Glaucoma can usually be treated with medications, laser, or other surgery. That's good. Next question. Laser surgery can be used to halt the progression of diabetic retinopathy.
True.
Very good. That's true. So here, a special beam is used to shrink the abnormal vessels or seal the leaking vessels, okay? Laser surgery has been proved to reduce the 5-year risk of vision loss from advanced diabetic retinopathy by 90%. I took these questions from somewhere. I thought that by the time we go through this lecture, we should be able to answer this. That's why I'm reading it like that. Okay, so the next question, we have 3 more questions. People with diabetes should have regular eye examination through the dilated pupils. True or false? That's very easy. And the reason is obvious. Good. Next question. Cataracts are more common in people with diabetes. True or false?
True.
Yeah, I won't even wait because I know all of you know this by now. Question 9. People who have good control of their diabetes are not at high risk for developing diabetic eye disease. True or false? I want a volunteer. And the person should explain.
True.
All right. Yeah, why are you saying it's true?
Yeah, because
yeah.
For me, I would say false.
To me, since the major inciting factor or the trigger is possibly the deposition of glucose and maybe the damage of blood vessel due to diabetic due to elevated blood sugar. I think when you have good diabetic control, possibly it will reduce the risk.
Yeah.
Even if it's not avoidable, but at least it will reduce the risk.
Yeah. But it will eventually happen. If you remember, one of the risks, very good. Thank you, Patrick. If you remember, one of the risk factors I talked about was duration of diabetes. So the longer someone lives with diabetes, the higher the risk of developing. So even if your sugar is tightly controlled, your glycated hemoglobin is always less than 7, after 20 years, the risk of developing diabetic retinopathy is 60% for those who are type 2 and almost 100% for those who are type 1. So the longer you stay with diabetes, the higher the risk. All right. So good. So the question, people who have good control of their diabetes are not at high risk for developing eye disease, is false. So that's the reason. All right. Good. So let me read. Even with good control of glucose, there is still a high risk of developing diabetic eye disease. However, studies show that careful management of blood sugar levels slows the onset and progression. So it doesn't mean that blood sugar doesn't have to be well controlled. Controlling it only slows the onset, okay, and progression of the diabetic retinopathy. That means screening is important. No matter how well you control the sugar, you have to screen, because when you screen and find the abnormalities early enough, you can treat with either laser or with these intravitreal injections for macular edema to prevent loss of vision. Last question. All right, so last question. The risk of blindness from diabetes can be reduced. Is that true or false? The risk of blindness from diabetic eye disease can be reduced.
Yes.
Very good. So it's true. So, and it has to do with early detection. So screening, early detection, timely treatment, okay, can help to reduce the risk of diabetic eye disease. Thank you all very much for your attention. I'm available to take any queries, any question you have on this topic. Anytime. All right. I wish you all the best and have a nice evening. Bye-bye.
Thank you very much. Bye.